listening to Community Health Watch on WNHHLP 103.5 FM, New Haven's home for community radio. Insightful conversations, impactful ideas, and voices shaping our community and beyond. Let's begin the dialogue.
And welcome to the Community Health Watch Show. We're here today with Dr. Onyema Ogbuagu and my friend Reverend Clayton, who is from Walters Memorial in Bridgeport. We're here today to talk about how clinical research has saved lives, and particularly we're going to look at respiratory disease. Dr. Onyema Ogbuagu is an American-born, I have to say that since he's out of the country, an American-born infectious disease physician, educator, researcher, and clinical trial investigator who was raised and educated in Nigeria. And Reverend Clayton and I met this incredible doctor during the COVID-19, and his leadership for our communities during that infectious disease was just incredible. And we've partnered with him in so many other ways. He's not only a physician, he's a teacher and a preacher and a musician. He's got a lot of things going, and we're just so happy that we could get him. He's in China now, which just shows his dedication to helping us at this critical time when, vaccines are being talked down and not talked up, when COVID seems to be returning and people are wondering where and when and if they should take the COVID vaccine and how safe it might be. And so all of these questions we hope to address during this show. And we got the man who can answer all of the questions, and I'm so happy about that. And so Doctor, you can just give us a little background again about, when we met you, how rapid that pandemic was and how quickly you guys were able to get a vaccine and the efficacy of that vaccine for so many.
Yeah, so first of all, to my friends and co-hosts here, Reverend Perry and Reverend Clayton, always nice to speak with you. Your passion and advocacy about around educating our community around health issues is paralleled, and I think very critical, and I think ever more so critical in this day and age, to be quite honest. And I always love participating in these events to contribute whatever I can. So I think I've learned, and history repeats itself, that sometimes the public's memory is short, right, around illness and disease. I think it's playing again in regards to vaccinations. I think in an era where the value of vaccinations are being questioned, I think we just need to dial back just a couple of decades and think about how ravaging influenza would be, wiping out significant portion of the population. We think about diseases that have been eradicated, like polio and measles, that were rampant, and even if people didn't die of them, I mean, they were quite significantly disabled, right? Polio was a disabling disease. And so I think, like everything else in medicine, people think that because things are fine now, we can drop some of the inventions that got us there, but people don't remember that we are where we are because of those interventions that we've maintained and sustained over the years. It's not so long ago, 2020, right? Like in late 2019,
Right.
December, we started to hear about this, very unusual disease, respiratory illness. And like many of these infectious disease outbreaks, it ended up being a physician in the ICU, right? Some of those frontline providers who take care of patient zero, always the typical way we talk about where the outbreak initially starts, and people die. And then when there's a cluster of deaths dying the same way, respiratory illness, and people start to ask questions, what's going on? In an era where global travel is, ubiquitous, I mean, people moving from one area to another, it doesn't take much from a fire lit in one part of the world to really spread across the globe. And that's really what we found in with COVID-19. And I think even though some of the real established reports were in March, I think there's enough evidence that it probably was circulating here prior to some of the detected cases. And like any new infectious agent, the public was not ready for it, right? Our immune systems were not ready for it,
Right.
right? Because the novel virus had unique characteristics. And so it took a devastating toll on Americans, right? Over 1 million deaths, right? It robbed us of our older folk. I always mention how, driving from, my home in Connecticut to work, on the way, I passed by cemeteries, and I remember seeing just so many more gravestones in
Mm,
some of those areas as I drove to work, especially during the peak of COVID-19. And so, of course, there was a global health threat, and something happened that was unprecedented. I think, our government initially slow walked, but eventually did take it seriously. And what happened was an unprecedented cooperation between the government providing funds, pharmaceutical companies,
right.
academic institutions like ours, researchers, like everybody came on board. And we did get a leg up because there was a previous SARS-CoV coronavirus, right? The prior outbreak, I think in 2003. So we kind of knew about the virus and we knew how it operated. We knew how to attack it. And so when SARS-CoV-2 then happened, we were then able to just really come together, work together, and have a vaccine produced in less than a year. And I think while we saw huge efficacy of the vaccines, again, the modeling suggests that maybe over 1 million lives saved, at least in the US, maybe up to 14 million saved globally, if not higher. Those are some conservative estimates by individuals receiving the vaccines. Unfortunately, I think that because a new platform was deployed, which should be celebrated rather than tarnished, right? A platform that can be rapidly deployed, easily scalable, mass produced in the event of an emergency, which are mRNA platforms. They worked really well. I was one of the clinical trialists, so I was definitely involved in administering this to children, to adults. My own kids received it. I received it. Both of you, received it. We all got the COVID vaccine, and we're all the better for it. Unfortunately, like any new platform, it's been maligned, right, because of some concerns about side effects. And I think it's really established science that the benefits of the vaccines far, 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 far outweigh any risk that did occur. Of course, there's no vaccine that's 100% safe, but the advantages of the vaccine far outweigh any rare side effects that tend to occur. So we celebrate that, and unfortunately, I think we're in an era now where we're no longer monitoring the disease as much as we should. And Rev, both of you. One of the ways that predicts community circulation of COVID is wastewater surveillance, right? So people spend their time, collect wastewater from a region and try to find out how much virus in it. And that usually correlates very well with clinical disease. Based on those estimates, as currently now, it's estimated that almost 1 million cases occurring every day of COVID undetected. Even if that's a crazy estimate, let's even cut it by half and say there's 500,000 cases happening every day. That's incredible community spread of COVID. And anecdotally, we hear of people getting COVID for the first time. I had my first episode of COVID in July. Since the pandemic was my very first time to get COVID. And the one thing that's clear for me was that since we stopped offering boosters as frequently as we should, I think my last shot was in October last year, and I got sick in July. Clearly, I think my immunity had waned from the vaccine, and then I became susceptible when I went on a foreign trip. I want to emphasize
Mm,
something here. COVID is not yet a seasonal virus, right? We're
mm.
seeing waves in the summer, right? We had peak case, in July, that's when we had like the cases starting to rise even in summer. It's not yet a seasonal virus. So this mindset that, like we do for flu, let's wait till like September, October, get it to cover us the winter season. COVID is not a seasonal virus yet. We have cases in the spring, we have cases in the summer, and we have cases in the winter, the virus continues to mutate. And so more than ever before, in spite of the surveillance issues we're having, etc., I think we need to get the word out that COVID continues to circulate and that we need to work hard to stay protected against it.
Doctor, when you contracted COVID, did you do the Paxlovid or did you just fight it out? What happens with people when when it happens to you? What are we supposed to do now?
So I'm happy to share that, personal story because I think some people can relate. So what I will say is I went abroad. I went to Africa, to go visit family. And then I think a few days in, I started to have a sore throat. Initially, I thought it was just dry air or something. It was very dusty, like arid, the parts of Nigeria I went to. But then it persisted for a while. And I've actually anecdotally heard, that the more recent variants, people tend to have like this like really sharp sore throat or
Oh,
kind of feeling. And so that's what happened. I didn't really have too much of the runny nose sore throat, but then a day or two into the sore throat, then I started to have fevers and weakness. And I describe it as almost like a flu like no other.
right.
We all get a cold once in a while, but this one hit me. Like it got me really fatigued and really tired and fevers and very uncomfortable. So I actually didn't have any doubt that it was COVID. So of course I had to
Mm.
confirm the test at home, but I was so sure about COVID, I didn't even think I needed to test. And of course, so initially I tried to write it out. I'm like, I'm healthy, I should be fine, but I'm pushing on my late 40s, right? So it's not like I'm a spring chicken 20-year-old. But anyway, really tried to write it out, but I felt sicker and not better. And what really terrified me at some point was I started to have vertigo, so which means that, I'd had the
Oh.
sensation of like the room spinning around me, which can happen sometimes with upper respiratory infection. So I thought, okay, this is now serious. It's now even affecting my balance, etc. And I was even worried, like, oh my goodness, could this be a harbinger of my going to have long COVID after this? So yes, of
Oh.
course, I called into my provider and got Paxlovid, and it did work. It got me feeling better, but I was sick at least for a week to 10 days. But glad to say I'm now better.
Oh, that's amazing. I think that most people just don't know what to do. I think the idea is I can write it out that it'll just go away. It'll just disappear. I'll get better. But people who have compromised immune systems, I think that would be difficult for them. And for people who may not have an adequate care provider to call to say, can you give me this? Can you prescribe this? And I think, hearing from you, this may help a lot of people at least have some options when something like this happens. I remember the last time I got COVID, I must have taken the COVID test 6 times because I didn't believe the outcome. And then after I found out that, yeah, because someone said, oh, the kits are old, so they don't really give you an adequate reading. You got to go. So I went to CVS and got some more kits, and the results were still the same. And whether or not, I guess I feared the Paxlovid because I didn't know too much about it, how it worked, and if perhaps if my immune system, since I have been taking the COVID shots as offered. And Doctor, let me just say this: there is a new COVID I just found out shot for seniors, and it's made by Moderna. It's called next something. What is it? It's called next something, and there are two. One is a low dose for seniors, and then there is another one that's also out. Spike Vax is
Like,
one, and then the other one was Next Spike, SPIKE. It says a lower dose for seniors over 65. I don't know if these vaccines are still being produced for us with where we are in this country, and are they available free now to get the vaccines? And I know that Moderna and Moderna and the one that you did, what was that one?
Pfizer.
Pfizer, yeah. So are they cutting back on production because the idea is that they're not gonna be supported by the government?
So that's a very complicated question. I'll try to answer some of those. So, So usually every year, and I think following the pattern of the flu vaccines, the CDC or FDA would recommend the strain of a virus for which vaccine should be produced against. So very early on, I think mid-year, June, July was when there was guidance around what strain of COVID to produce vaccines against. And so you saw companies like Pfizer produce a version of the vaccine, and test it against the circulating variants to make sure it would hold up. So that was done already. And of course, the big mRNA vaccine producers for COVID-19 are Moderna and Pfizer. And so that's been done already. Moderna really depended on government funds for a lot of their COVID work. Pfizer works independent of that. So there's a little bit of difference in regard to how much impact government support or lack thereof, at least financially, would do that. You are aware that the government has also pulled at least $500 million of research funds from whatever collaborative projects that were done involving government agencies and mRNA vaccines. And so we're yet to see kind of the impact on that. And of course, in that environment, the concern would be what would even be the posture of regulatory agencies towards newer mRNA vaccine products. It's already reflected in the guidance for the COVID-19 vaccines in this era. The guidance now is, first of all adults, still recommended to get it. However, there are caveats. I think strong recommendation for elderly people 65 years and above, just by age criteria. But then the language on the CDC website is for some or most people within the age of 18, right, and 64. And I think what they're trying to say there is that, certainly for people who have underlying conditions, like you mentioned, Rev Perry, like, people who have immune compromising conditions, et cetera, which the huge list, right, lung conditions, asthma, COPD, other immune compromised, HIV, people on long-term steroids, like that, should receive the COVID-19 vaccines. But because of the lack of clarity, especially among 18 to 64, I think there's concern about that. And then for children, 6 years to age 17, the language is even softer. And it says that, physicians should discuss the risks and benefits of vaccination with children. Now, of course, the concern is twofold. One is that these are agencies that should provide guidance to pediatricians and doctors as to, how they should offer the vaccine. And they definitely have been softened, if you will. The language certainly has been softened. But then downstream also is how would then insurers then react to this, right? Would they elect not to, for example, cover pediatric vaccines, given that the CDC is not recommending it strongly in that group? So again, it's still early phases as we go into the flu season, if you will, or the fall-winter season for respiratory viruses, and the impact some of these recommendations would make on uptake of COVID-19 vaccines is very, very concerning.
Let me chime in just a minute. What is the efficacy of taking both the flu shot and the COVID shot? And also, another question, is there an approved combination vaccine for both?
Yeah. So, so to answer your question, there's been studies showing that the flu and COVID vaccine do not necessarily interfere with the immune responses to either of the vaccines. However, there could be some chance that when they're administered together, people could have some more reactogenicity, so things like fevers, etc., which in those cases it may be prudent to separate them if that certainly did occur. I think that, again, many of us really are advocating for respiratory viral vaccine platforms that integrate more than one viral platform. Certainly the data is there. I think Moderna's ahead with their flu and COVID vaccine combo. But none of them, to the best of my knowledge, has been approved yet. But many of them already have been fully studied with immunogenicity and safety data, which will support its use. And I'm aware that other companies are also beginning to explore multiplex vaccine platforms for, other respiratory viruses like RSV with human metapneumovirus, or RSV and other vaccines. Now, the good thing with the RSV vaccines is that we're seeing that it may be active for more than one season, right? So you get a shot, let's say in 2024, 25, it may protect you to 25, 26. So initially there was interest in combining that with a vaccine, but since its longevity is a little different than, let's say, flu or COVID, I'm not entirely sure that those should be combined, but flu and COVID probably will make sense. So anyway, we are, it's lots of active investigation on how to work on combination vaccines, and I think it may help with uptake, right? We saw for 24, 25 that people took the flu vaccine way more than they took the COVID vaccine, including older individuals, right? So maybe a combination of vaccine strategy may move the needle. I think the COVID will benefit from being attached to the flu rather than the other way around, just because of the public perception around that, especially the mRNA vaccines.
Dr. In terms of these vaccines, and Dr. Clayton was talking about the efficacy. How how are they developed to the point where we know, I mean, that people can have confidence in them? Like when I took the RSV, I just took it because I'm at the age where I don't know if I don't take it, well, I'll survive. So when I hear this out there, I don't question the science because I believe in the science. I mean, well, I did up until recently, but I know that I know that you researchers do your work, you do your testing. Can you just help others to understand that kind of background to the research that goes to bringing these drugs to market?
Yeah, so again, that's always a loaded question, but let me address some of the things you mentioned earlier. So RSV doesn't mutate as much as flu and COVID, right? Which could explain why you have that much more longer term durability of protection that the vaccines provide. Now, for flu and SARS-CoV-2, the cause of COVID, right? Those viruses tend to mix and match. So, for example, the new COVID variants that were circulating, apparently they're choosing cloud names, right? So one was like Nimbus, and then now we have Stratus is the current COVID-19 strain, and that's a recombinant strain from two different Omicron lineages. So it's almost acting like flu, where you have two different viral strains sharing their genes and producing descendants that looks a little like both of them, but a little different. And the whole goal is for the virus to evade the immune system and continue to circulate. And most times these new variants have an advantage in regards to attachment to the spike protein and perpetuating the viral life cycle compared to the preceding ones. That's why when they come in, they take over and become the predominant circulating strain. They outcompete, what's already out there. So because, flu and SARS-CoV-2 change, we also need to every year redo the vaccines to make sure that there's a match between the vaccine and the virus. In years where the match is poor, efficacy can be as low as 20%. And years where match is high, efficacy can be as much as 70%, but it's a tiered efficacy. Like the efficacy for preventing illness may be a little lower, preventing emergency room visits would be a little higher, and certainly preventing things like hospitalizations even much higher. So for example, from 24, 25, the COVID-19 vaccine efficacy ranged anything from like 40 to like 75, depending on people's age group, etc. The flu vaccine was roughly about 45% effective in preventing some of the like emergency room visits, etc. So again, I think the reason why we need these reiterations of vaccines are to keep up with a changing virus. But remember, many times it's retroactive, right? So the virus changes. Sometimes by the time you're making the vaccine based on what was circulating in July, by the time you get to September, it's a new virus that's circulating. So these are huge challenges. And that's even the more reason why mRNA platforms are needed more than ever. Of all the different vaccine technologies, mRNA platforms are those that can be made much more quicker, manufactured to scale quicker, and deployed much more quicker, right? So, and I always say that this is a platform where, let's say you got it so wrong in September, you can probably redo it and have something ready for December and January. So again, that's my concern about crediting of the mRNA technology. And then your last question is, again, again, speaking to community, people that look like me, I understand skepticism about vaccine platforms, but take it from someone firsthand who's been at the forefront of getting these vaccines through clinical development. Lord knows we put in a lot of effort to make sure that these vaccines are safe. We monitor people actively. With the Pfizer vaccine, we monitor people for 2 years. We capture, side effects when they do occur. We stop studies if we have anything that concerns us. Many times before we test in humans, we have tons of data in animals and closely related species like non-human primates to make sure that we have it exactly right. And we're regulated, right? Like we have oversight. We have oversight locally, even our institutions. We have locally for institutional review boards. We have even like the grand regulatory agency, which is the FDA, have strong oversight of the trials. And so when any of these get the blessing as being safe and effective, the public can believe it. If there's a conspiracy, tell me how powerful that will have to be to have government officials involved, independent academic research like as myself involved, all hospitals involved, doctors and pediatricians. That has to be, once a conspiracy gets to become everyone, it just inherently can no longer be a conspiracy, right? So again, these vaccines are rigorously studied. Remember, not every vaccine makes it through, or those that need more studying don't get approval until they meet that safety bar. So again, just to reassure the public that nobody throws these things out there. I took the Pfizer vaccine that I was part of advancing myself. I gave the Pfizer vaccine to my kids and my friends, right? So and nothing speaks stronger than research you're involved
And you
with.
gave it to them.
Exactly. And you take it yourself, right? Shows how much faith you have in that. So again, there's this silly thing about, hey, you like we talked about, like you write it out and things like that, especially if you're older or you have underlying immune compromise. But even for healthy individuals, right? One thing we don't talk about much is that you can be healthy, but when you have COVID, you can spread it to your grandma, you can spread it to your parents, you can spread it to a friend who's immune compromised. If you're a healthcare worker, you bring it to the hospital. If you're someone who works in cubicles, you spread it to your coworkers. And so you never know like how much downstream impact you can have, right? Getting somebody else sick. So again, it's always a team sport. Masking was always a team sport. Getting vaccines is a team sport. If enough of us get vaccines, we can halt community transmission. If not enough of us get it and we keep doing the numbers which we're doing, it only helps fuel community circulation of the viruses. So we don't do ourselves a favor as a community where some do the right thing and some don't.
Let me slide in here just a moment again. But first of all, we want to thank our listeners again for tuning in. You're listening to the YCCI Community Health Watch Show on WNHH 103.5 FM. Dr. O, are you currently involved in any new studies? We've heard that you were in Liberia working on a vaccine for monkeypox. Could you tell us a little more about that, please?
Okay. I wasn't working on a vaccine for monkeypox. So what happened was in Liberia, I've worked in Liberia since 2017. Liberia is one of the poorest countries in the world. They've had 2 major disease outbreaks, which everybody knows, right? So there was Ebola that happened, I think, between 2014 and 2016. Lost quite a lot of physicians, healthcare workforce. I think they had the largest outbreak in the 3 countries in West Africa, Liberia, Guinea, Sierra Leone, that were involved. Barely had they recovered from Ebola, they got hit by COVID, right? Which again happened, again across the world, but again, it's by epidemic upon epidemic. And now visiting Liberia to go do some of my research and clinical work, they're currently experiencing an Mpox outbreak. Okay, Mpox used to be formerly called monkeypox. Okay, these are very painful ulcers that almost look like herpes, right? Or sometimes they're these big, swellings and rashes that people have all over. It's ravaging through Liberia now. It's a virus that's spread from person to person, and it's acting like a sexually transmitted infection. So, reproductive age individuals coming in all kinds of genital lesions, and so you have this poor country really struggling to contain the outbreak. And I think, so I'd worked there for a while. I'd helped train, the doctors, and it was great to see one of the physicians I trained in infectious disease, who is now board certified, who was actually the lead for the Mpox response program. So I visited the site, worked with them, saw patients, helped provide clinical care as well. And we continue to find ways to support some of their work. I went there because we have a grant from the NIH to support research training capacity in Liberia. And so, of course, part of what we'll do is try to make sure that they're better prepared to address local health problems, but also, put from a scientific viewpoint and really generate the evidence that they need to optimize the clinical care of their patients. But then back to my domestic work, your question was what's going on. So both of you know that my passion is in HIV medicine and advancing therapeutics for HIV treatment and prevention. One of my proudest moments was, mid-year June, where the 6-monthly injection that we'd worked on was approved for HIV prevention. So it's a shot in the belly. It's a subcutaneous injection given twice a year. There were 2 sister studies. I was involved in the study that looked at men and gender diverse individuals. There was another study in Africa that looked at women. Can you believe, Reverends, that not a single woman who got the 6-month shot acquired HIV during the time that the reports were released? It was 100% effective.
Wow.
Right? And even for the men and gender diverse individuals who we gave that, there were only 2 infections out of like 2,000 people, and it was like 96% effective relative to people receiving nothing, or what we call, we didn't use the placebo, but compared to what we call background HIV incidence, so what HIV would have been if no treatments were given. So that's very, very exciting. Next, we're going to work on a once yearly shot for HIV prevention, and we will soon start to enroll people into that. So that's HIV prevention. And HIV treatment, working on long-acting treatments. We also have that same shot that we use every 6 months. We already have that approved for HIV treatment. There's injections now that we're going to be investigating to give 3 times a year, intramuscularly, also to treat HIV. So that's also in the works as well. There's also we're using antibodies, which are like modified proteins to also try to treat HIV. We're giving that twice a year, and we have a few people who've come off of pills and are just on those. We presented some of that at scientific conferences, who are on twice yearly infusions or shots and not taking pills and staying virologically suppressed. So a combination of one HIV medication as well as antibodies. So these are exciting studies. I think bottom line is that we are really advancing HIV treatment by leaps and bounds, and that trying to introduce what we call long-acting therapies to make treatment much more convenient for people. And it's letting us treat people who ordinarily would not do well with pills, people who forget to take pills, people who have social mental health challenges, they're homeless, they have mental health issues, psychiatric issues, substance use issues, things that interfere with, being able to remember to take a pill every day. So we're finding we can treat more people, we can achieve success with outcomes for many of those individuals. Now, next year, we would then, back to your respiratory vaccines, we would be hopefully working on combination vaccines for other respiratory viruses as well.
That's amazing. It is truly amazing. Are these yearly shots and 6-month shots rather, are they readily available? I mean, is it a cost that prohibits people, or is there still a stigma that might prohibit people from getting these? And how do you work around that?
Yeah, that's a great question. So, one of the huge barriers for people, first of all, being engaged, they're multiple, right? So you can even start from testing, right? Because testing is your triage. Testing is where if you're positive, you go to treatment. If you're negative, we assess your ongoing risk for HIV. And then we can start to talk about, hey, there's a pill for this, there's a shot, etc. So people don't get tested because they're scared. They're scared of what a positive test would mean, how it would
Right.
impact their life, right? And so that's why sometimes people have HIV and we get to discover it late. We're still having, even in the state of Connecticut, 20 to 25% of our new diagnoses are late diagnoses. One of every five, one every four. When they're diagnosed, they're already really later on in their HIV infection. That's something that should never happen. But again, that speaks to stigma. Even when people come to us and we offer them pills, remember the pills are HIV medications. And so if an intimate partner, boyfriend, girlfriend, partner, parent, friend sees a bottle of HIV meds in your bag, on your
Mm.
in that cupboard where you hid it, it could change their perception of you as a high risk individual, as someone who's out there being reckless with their sexual life, right? Yeah,
Yeah.
judgment and everything. So people sometimes don't take the medicines that they're giving because of some of that. Sometimes it's side effects, sometimes it's other things, it's cost access. All those things are really important. So anyway, the reasons why we've advanced injectables are to address some of those issues. So that stigma people feel with having to take a pill, the injections are given.
Mm.
So it's much more discreet, right? People go see their provider, almost like a lady will go to get contraception, like an implant or something, right? Done in
Mm.
his office, is discreet. It's empowering for individuals, right? Because they feel this is something I can do to keep myself healthy in spite of having a partner who either lies to me about their status, doesn't tell me about their status, but I'm protected. I have this shield, right, or armor that protects them. So, and even in our clinical trials, we've seen that injectables outperform orals when it comes to HIV prevention because people just don't take the pills, but we give the injections.
Oh.
We keep a calendar. We tell people it's now time for the next injection. So there's some kind of built-in support when you have to go to clinic to get a prevention medication. So we found that to be like extremely powerful regarding that. But it doesn't eliminate all of stigma. I think one mistake we've made in HIV care sometimes is we've even called ourselves HIV clinics, right? So anybody walking in through the door is labeled. So now we've been very fine. New York calls their clinics things like Center for Special Services. Now at Yale, we have a Center for Infectious Disease where we don't just do HIV prevention and treatment. We do treat an infected leg. We treat a skin rash, right?
Mm.
We vaccinate for travel, right? So I think we've also been careful about the labels that we put on the places where we deliver care and how we deliver care to be much more discreet because stigma is a huge barrier. We always say in the HIV world that when we talk about some of our goals, you must have heard about the 90-90-90 or 95-95, which means you want 95% of people with HIV to know they are infected, so they have to be diagnosed. You want 95% of those who are diagnosed to be on treatment, so you want to make sure you're treating people who are diagnosed. And then you want 95% of people who are diagnosed to untreated to be virologically suppressed, right? So you want the treatments to work so the virus is low. If you do that, that takes us on the path of ending the HIV epidemic. But we say that the fourth 90 or the fourth 95 is stigma, that a barrier to achieving every single one of those steps to improving the outcomes of HIV is stigma. Right. And so I think we need to all just work on ourselves about the way we label people that have a disease, the way we treat people, even at the family level, the community level, right? And let's be honest, even in our community is an issue. I think I've shared this story with you, Reverend, before, right? Like, someone goes for a Thanksgiving event with their family, cookout, like in our community, that's like a family thing, right? And someone with HIV, touches a spoon or a bowl, takes some food, and that's the last time anybody goes to that bowl or thing. People
Right.
know that, and it makes them feel unwelcome and they're stigmatized and judged and treated as less than. So we need to work on stigma. HIV is like everything else. We don't stigmatize people that who have diabetes that much. I would even argue we stigmatize obesity that much in our community. So we certainly shouldn't stigmatize HIV. And I think that allows individuals who either have that or are at risk for that seek out care where they can.
That's incredible information and uplifting information. Because you're absolutely right. I remember even when a person died and they died of AIDS, people would be afraid to touch the body or go near the body in the casket, or they would just cremate them automatically because they thought that they could be infected. And these folks' lives are just so disrupted by this, already without the stigma, just the fact that you carrying this. But I've seen commercials on television of your work for the new vaccines for this, and I'm so proud to know that the man behind the scene is a friend of mine. Yeah, and one other thing, Dr. O, I was watching something about the measles vaccine break, and one of the studies was saying that, I think it was in Texas. They said, "Oh no, we don't need the measles. People should have a choice." And they said, "But they always have a choice whether to take the vaccine or not." But if you're be in the school, then taking a vaccine that's going to help, it's like a herd immunity. If everybody's got it, then it safeguards people who may have comorbidities and come into a classroom. But if everybody doesn't take it, then it's just widespread. So when you talk about respiratory diseases, it's so important, I think, for us to note that we can be carriers for people who have compromised immune systems as well as ourselves.
Yeah, so Rev, it's not far-fetched, right? So we don't even need to build the hypotheticals, right? So, for example, we know that communities where vaccination rates are, so for example, without naming names, but there are communities in New York, for example, where people are not vaccinated. There've been outbreaks of measles ongoing even in the past, even while I was in training, right? So
Mm,
it's been recognized, right, that once you fall below that herd immunity, and for measles, it's as high as up to 95%, right? How to be vaccinated protect the 5% who aren't, right? We know that where vaccination rates fall, especially start going down to the 80s, there's already modeling showing that there's going to be a resurgence of measles and potentially even resurgence of diseases that should have been eradicated, right? A good example right now is, Gaza is a place that suffered from war, and their vaccination
mm,
programs have certainly dwindled. They are experiencing a resurgence of some of these childhood illnesses in that context. So there are already case studies where, again, suboptimal vaccination rates promote resurgence or spread of some of these illnesses. And again, I don't know how any of us would be comfortable. Yes, measles has claimed, single digit kids' lives, but, God
mm.
forbid if you were your kid dying from a preventable infection, right? That's totally devastating for a family. That's devastating for parents, and that's an event that shouldn't really happen. And I hope it tugs at the conscience of society whether it's okay to you know uh, allow these kind of events to happen to the most vulnerable. Children are vulnerable, right? They're
Yeah,
not
yeah.
of age to make their own decisions, and I think it's us as parents and adults to protect the vulnerable among us. So we're starting to see some states, I think like Florida, considering pulling back
Hmm.
mandating childhood vaccines in schools. So unfortunately those may be case studies for us to see what those impacts are. And one last thing I'll just say is that, even in states where, vaccines are mandated, there's always been pathways where if you've had like a
Right.
severe reaction to a vaccine, don't get it again. Those protections have always existed. In some cases where they're true, religious exemptions, although some states try to narrow that. But we find that when you relax some of those, the rates of vaccine refusal or hesitancy actually go up in the absence of some of those mandates. So, again, these are things we're very, very concerned about. I know the American Association of Pediatrics has,
Mm.
in some ways gone rogue and, stuck their foot down as to how they feel about some of the childhood vaccine recommendations currently. And we'll see where those go. I think, proof will be in the pudding, but I hope that we don't have to learn from harm that occurs.
Right. Right. Yeah, that's so important. I think bad science is one of, I wish there was a vaccine for that. You know, people who tell you, taking this is going to be harmful, your children are going to be autistic or something. We need to, and that's why it's so important to have credible scientists like yourself and researchers who can come into our communities and talk talk to us about, these issues. And I think that's why we appreciate you so much for being on this show. You just when I thought you were not going to make it, I was like saying, "Oh, faith is the substance of things hoped
I
for."
saw that. I was like, let's make this prayer come true. And I think programs like this are the booster vaccination against misinformation and disinformation, right? But we got to continue to get the message out and the word out to communities. I mean, when did cure or suffering an illness become more important than prevention, right? Prevention always, comes before cure, because we're not always successfully cure. Harms occur, lives are lost, and it's just a trade-off that I don't think we should accept as society.
The children who have compromised or who have comorbidities ask their physician about taking the COVID shot, because it has to be some pathway for them to be included, right?
So I will say the language is not exclusionary, to be fair. The language just says it should be a conversation parents should have with, and it's from 6 to 17. So there's also a little bit of silence as to 0 to 5, right? So newborn to 5. But for 6 to 17, they're not saying don't do it. They're just saying discuss with providers. But then if you're an insurer and you see that the guidance is discussed with your provider around this vaccine, it almost incentivizes them to not offer universal coverage, right? For that, right? To somehow disincentivize from everybody going to get it because they have to foot the bill for that. So that's the concern that we have around that. There's a little bit of a paradox there because, again, it's, immune compromised children should be vaccinated, but they're also sometimes unlikely in some cases to respond to vaccines, right? So they should be vaccinated, but sometimes that same immune compromising condition that makes you vulnerable to severe disease also, right, diminishes your response to vaccines. So in that case, you can still see the argument where even vaccinating healthy or anyone at all who could be sick, again, thinking about the herd immunity, gives us a second layer of protection for the more vulnerable among us, right? So that's again why I keep emphasizing team sports, and that when we think of it, I know there's a whole push to make decisions individual, but as public health experts, we have to think about things from a population level. And sometimes those may be a little antagonistic to each other, although they should be complementary. And that would be one scenario where, again, a population level view would serve the immune compromised population well.
So should children, one question quick, should children take the flu shot? Because I know at one point we were advocating that all the children should take flu shots, but is that, you think, something we should try to tell our communities that they should do, or it's safe to do?
So the risk for flu is actually bimodal, right? Like it can affect younger kids under age 5, right? And then affect older individuals. So younger kids, right, under age 5 are actually immune compromised and vulnerable to severe outcomes with some of these infections. People forget that. So again, it's certainly something I think kids should definitely receive vaccines to protect them. We'll see where the newest guidance falls, but I mean, that's always been the case. Now, only in cases where we have like severe shortages of flu vaccines, then a rational public health approach can then be, let's target groups, like, so people about 5 people, you know what I mean? We're not there now, right? We're not in a period where we're struggling with flu vaccine supply. In those instances, I can understand triaging out healthy people, right? And let me also argue again from a public health standpoint, there's value vaccines bring beyond just going to the ED. Can you think of how many working days, even for healthy people, are lost in the context of an illness? That 5 days people stay home, or those 3 days a construction worker can't work, times, now the COVID positivity rate, I think, is 10%, like of all ED visits, 10% are COVID, something like that, right? Can you think of the burden to healthcare workers who miss their shifts because they can't go to work, right? Sometimes we don't think about the economic burden of influenza-like illnesses. It comes to the billions every year of productivity lost, right? because of preventable illnesses. But we don't study this in clinical trials, right? We don't, those are not like the endpoints that we even rigorously study scientifically. I mean, of course, we can always like do modeling and do the math, etc. So again, as we start to have this argument of the role vaccines play in our lives, I think a much more robust, balanced, public health skewed approach to what these vaccines do for us as a society, right, is critically important, right? I think what are the estimates, like what 20 million people can walk today, right, since ever polio started because they didn't get polio, right? Forget about death, right? Just think about the disability people have, right? So these numbers speak for themselves. And I think we're at critical crossroads as to us a reckoning around the role of vaccines in our lives. And I think some of us are pro-vaccine. This, you know, again, vaccines are not perfect. Mistakes have been made. There can be rare harms that occur. I'm not saying those don't happen, but I think, you know, vaccines are one of the reasons humanity has experienced greater lifespans, period.
Listen, we just want to take the time to thank our listeners again for tuning in to the YCCI Community Health Watch with the Cultural Ambassadors on WNHH 103.5 FM.
All right. Let me give you one last example, Dr. O. When I was pastoring in Harlem, one of my members, a young girl, had twins, and the twins died. And she claimed that it was due to the fact that, you know, they gave them some kind of measles or chickenpox or some kind of vaccine. And she was trying to get me to get a lawyer for her and go into court, and she wanted to fight this. And when they did the autopsy, they found that the children, that they had cocaine. And so the parents who had these little cocaine spoons had used one of the spoons, had wiped it and thought it was clear, but the cocaine, and was using it to feed the babies. So, I mean, you know, it's a lot of research and stuff that we really have to do, uh, and not spread the myths because somebody gets sick or somebody gets hurt, to necessarily say, unless you can test and prove that. I think that's where we are. And I think that normally, you know, these non-scientists, they just make the assumption that because the mom said, oh, this did this to my child, but nobody did the research to find out if that was really true. And the myth just spreads like wildfire.
Yeah, so I think what we've all been harping, at least most of us health professionals, is people need to go to credible sources for the health information.
Yes, sir.
That's not Facebook. That's not WhatsApp. That's not Instagram. That's not Twitter, right? I mean, like, again, even if you're using those platforms, it should be individuals who are credible, right? And so I think, and unfortunately, I think in an era where there may be politicization of government agencies and things like that, I think we're also unfortunately doing ourselves a disservice where our public health agencies may be questioned by the public. So we need to start building back. There's, you know, well-meaning people in all our government agencies. I'm sure there are people that are thinking about the public health all the time. I think that we all need to just continue to try to rebuild the trust that we've lost and the reputation that we've lost over the years, and find better ways to engage the public. Don't cede any spaces to misinformation. You know, most of us opened Twitter accounts in COVID time. I was one of those. I used to hate social media, but, you know, I figured that could be a platform to get my viewpoints and the truth out. Many of us have done that. It's an uncomfortable space because, you know, I think some people are just, there's so much vitriol and hate online, right? Like, people hide behind a computer and say all kinds of god-awful things, but it shouldn't deter us from speaking truth to power, speaking the truth about science, and sometimes acknowledging our mistakes too, right? Like being comfortable to say, I thought this, I was wrong. You know, I think that actually makes us look more human and relatable. We don't always have to be right, but we always have to be honest. And I think if we keep that principle, we build the public's trust, and maybe things can be better.
We want to thank you, Dr. O. I mean, this has been phenomenal. And we're going to close with that because there is not anything more profound than that, which is a truth. And we just, again, appreciate you so much for taking the time out. I know you had to rush to get to the room to work to get the camera set up. But again, we thank you and our blessings to you and your family.
Thank you for having me.
Thank you again, Doc. Safe travels. Wish you well on your journey.
Yes.
You're listening to the Community Health Watch Show on WNHHLP 103.5 FM, your home for community radio. Stay informed, stay connected, and take charge of your health. We'll see you